Good afternoon, everyone. I thank all of you for tuning in on this virtual thing. Sorry we can't be here in person. We always would be stimulated by seeing an audience, but the pandemic, of course, does not permit that. As you can see here, that heart disease is the #1 killer, and 1/3 of all females in the world die from heart disease. And what I'm going to present to you is a case and come back to answer how we would manage this today as opposed to perhaps a few years ago. A premenopausal asymptomatic 40-year-old female on routine checkup has a plasma LDL cholesterol of 180, no other risk factors. In other words, with that story, there's no treatment recommended. The American Heart Association, the American College of Cardiology, developed a technique called the PCE to calculate the 10-year risk. In this case, this lady has a 10-year risk of 2.1. We only treat if it's 7.5 or greater. So this person would not get treatment. Many of us would feel this is a missed opportunity to prevent heart disease, given this lady has such a high plasma cholesterol. On the other hand, why not treat everyone with an increased plasma LDL cholesterol? And as you can see, the problem is here. The average female in their 40s has a cholesterol of 121, that is a LDL cholesterol, and males in their 40s, 146. The guidelines is to be less than 70 milligrams per deciliter. So the result is you would treat everyone. That as a problem, because only about 50% of females living a normal lifespan in the United States has a 50% chance of experiencing at least one cardiac event. This means, of course, 50% would be getting therapy that's not necessary. Because our calculations for treatment at the moment are based on traditional risk factors for heart disease, as you can see here. They have been traditional since the 1960s. The problem with these risk factors, most of them, as shown here in this diagram, do not develop until later in life. As you can see that the plasma LDL cholesterol in red increases exponentially with age. In fact, every additional decade of exposure to plasma LDL cholesterol results in a doubling of risk for heart disease. However, if you look at the other risk factors shown in yellow, these risk factors do not really come on until you're in your 50s or 60s. This is a problem because it's often too late for primary prevention. You want to know in the 30s or 40s. And so traditional risk factors, because they're age dependent, and most do not develop till the 5th or 6th or 7th decade of life, this means we don't have the armamentarium to determine who should get preventive therapy. We want something that is independent of age. As you can see here in the blue line, genetic risk, you're born with the same risk, you die with the same risk. If one could indeed harness the genetics to give you a risk score, it could be determined as soon as you're born or anytime thereafter. So what I want to show you today is that we have moved along in that area and are now in a position to think about that sort of thing. Epidemiologists have claimed for decades that 40 to 60% of risk for CAD is due to genetics. However, it wasn't until 2007 the technology was available for us to really look for the proper genetic risk variants. In 2007, we published the first genetic risk variant, which occurred at the same time as the Icelandic group also independently found the same variant and was published in the same issue of Science. This variant was found on chromosome 9, the small arm, which we refer to as petite or P, so became known as 9p21. It was associated with very small risk, but very common, occurring in over 75% of the world's population. We also found that 9p21 is independent of known risk factors for coronary artery disease, such as cholesterol, hypertension, or diabetes, indicating a new opportunity for both treatment as well as diagnosis. Soon, within the next couple of years, 9p21 was confirmed throughout the world, as you can see here, in over 60,000 cases. All of these were Caucasians, but also we got reports from Korea, Japan, China, East Asia, showing that 9p21 was a risk factor. Recognizing there would be many more, and it would require a large sample size, that's when we formed an international consortium, which is then called Cardiogram, which involved over 88,000 cases and controls, and it cut across 2 continents. Since that time, then 13 years later, we now have multiple risk variants, and we have replicated them in an independent population. And so we are in a position with these to try and think about how well can we predict coronary artery disease in young asymptomatic females, for example. The total genetic risk burden for coronary artery disease can be conveniently expressed in a single number referred to as the genetic risk score. It's then put on a chip. These variants are on a chip and can be screened for by simply taking a blood sample or saliva. The first attempt to predict coronary artery disease was in 2015, published in Lancet. And what these individuals did was went to clinical trials that had been done assessing the effect of lowering plasma cholesterol. Those trials are shown here. The total sample size was about 48,000. And what they showed in genotyping for those genetic risk variants, if you look at the low intermediate risk, those in red are those with the highest genetic risk score, and they're also the same group that received the highest dose of statin therapy. In essence, this meant using the genetic risk score, we could classify those who are at highest risk and who would benefit most from statin therapy. A next study was done, a large study, as you can see here, involving over 500,000 cases and controls. And Dr. Henaway used the genetic risk stratification. The sample size precisely was 482,269. And this analysis using the risk score was followed by another large study, as you can see here, which involved 288,978 individuals. The genetic risk score was also used to stratify for risk of heart disease. And the results are very clear-cut. Individuals with the genetic risk score, the top 20%, had a 3 to 4-fold increased risk for CAD. It also showed that the genetic risk score is relatively independent of conventional risk factors. The genetic risk score was more potent than conventional risk factors in detecting individuals at risk for CAD. Obviously, it's not only important to know that you can do risk stratification, you also have to know, can you treat it and will it respond to therapy? So this was the first study in New England Journal in which a large population of about 48,000 were genotyped, and they were analyzed, those who lived a favorable, what's called a favorable lifestyle, and those who didn't. And what the results showed, that those who lived a favorable lifestyle and were at high genetic risk, those who lived the favorable lifestyle had a 50% reduction in the favorable lifestyle, 50% reduction in cardiac events. Clearly very effective, showing that genetic risk was able to stratify, and it did respond to a favorable lifestyle, both diet, exercise, and non-smoking. So what you have now is a genetic risk score that has been shown to respond to favorable lifestyle. Also, as I indicated earlier, a safe and expensive therapy, namely statin therapy, has been proven to reduce the genetic risk for CAD based on genetic risk stratification. Now, as I indicated to you more than a year ago, we had planned to do the first trial, which is called the Genetic Risk Score for CAD here in Phoenix. Of course, because of COVID, we were approved to do that trial by IRB, but because of COVID, of course, we could not do elective research, so it's been put on hold until that time. But just briefly, what we hope to do, starting here in Phoenix as soon as we can, as soon as COVID permits it, this is basically what we'll be doing, is screening females at age 40 to probably about age 55. We can take blood or saliva, and then we will genotype for risk variants, calculate the genetic risk score, and divide them into high, intermediate, and low risk group. And those individuals who get a high risk group, they will be informed of what group they're in, and certainly then can see their own physician or see one of us in terms of what we can do about it. This will be the first that we know of genetic screening for the population in general. But as you can see, this will be a whole new approach because your genetics does not change in your lifetime. That's because your DNA doesn't change. And so the result is one can determine what your genetic risk is the day you're born or any time thereafter. And this is why we can do someone, say, in their early 40s with no symptoms, whereas if we depended on genetic risk factors, as I indicated earlier, they do not have that much risk at that age, and therefore we can't separate that 50% that is likely to get heart disease from the 50% who will not get heart disease. This certainly is a whole new approach in terms of screening, a whole new approach to how we will do what we call primary prevention of heart disease. And it's a great approach in the premenopausal female. The premenopausal female has very little heart disease. So instead of waiting until they get heart disease, this gives us the opportunity to prevent heart disease from developing. We honestly believe that utilizing the genetic risk score to detect one's risk for heart disease will represent a paradigm shift in primary prevention that has not been available before this time. I'd like to express appreciation to all of my scientific collaborators who participated in the discovery of the genetic variants, etc. And also, I thank for all the grant support that I received during this research. Thank you very much.